guys, today we are going to discuss gastrointestinal tract pathology. We'll start with the oral cavity. We'll discuss it very rapidly. Oral cavity pathologies are okay, first of all, with a general definition of gastrointestinal tract, so just to understand the issue we have. So it's transportation of food along the hollow tubes, transportation of food from starting from oral cavity until the anal canal, and everything which is related to physiological patterns, which are related to digestion, is in portion of digestive tract. Actually, we have 4 lectures about gastrointestinal tract pathology, and the first 2 lectures will be about hollow organs pathology. The rest of the lectures will discuss liver and gallbladder pathology. Also very interesting, very important. They are also part of the digestive tract, but they are not hollow tubes, and they have little differences. Okay. I'll start with oral cavity. So I remind you histology of oral cavity. So in oral cavity we have stratified squamous epithelial lining. So it's claimed as a moist stratified squamous epithelium, or parakeratinized epithelium is present in some locations. Parakeratinized or keratinized epithelia. So especially you understand the role of it. Then oral cavity is a tearing. Yeah. So we have food, when we intake food during the mastication, some particles can injure the epithelia, and that's why here must be the most tangible, most stable epithelia, which can easily afford for the mastication process, of course. Okay. Then which pathologic conditions are present there? So first of all, they're related to epithelia and glands which are present there. So here you see discussed next are more common conditions affecting these sites, like odontogenic cysts and tumors, might be benign or malignant. They are derived from epithelial and very rarely mesenchymal originated tissues, and related to teeth development. Of course, we have teeth. So, and what is a teeth? What are teeth? So actually, teeth are they are not bones. So that might be some of you heard about it. Yeah, tooth are bones, and they are part of skeletal system. It's for it was discussed for just schoolmates, because yeah, it's hard to differentiate it. But tooth are epithelial in origin, but yeah, there we have enamel, so which is very hard, and so most hard tissues, the most most solid organ, yeah, so which assist in mastication, and we have odontoblasts, which are producing dentin. Yeah, so which is supportive tissue, and also in the deepness of teeth we have a pulp, so where we have blood vessels, nerve innervation, and so then. Okay, caries. The most common pathology of tooth is a caries, and actually we have dentistry mainly deal with the caries. So what is a caries? It's a focal demineralization of tooth structure. Demineralization caused by bacteria. So you know that normally in oral cavity we have microflora, bacterial flora, so which are absolutely different bacteria there. So which and you share with it by kissing, by just eating same food. Yeah, you can share some saliva, and along with the saliva sharing the microflora. And just interesting fact, curious fact, that persons who are in marriage pair, yeah, so their microflora of oral cavity became very common. So the consistency of bacteria is pretty similar. And you might be heard that dentist said to you, yeah, so don't eat sweets, yeah, don't eat sweets in large amounts, so because sweets causing the caries, and it's particularly true. So actually, why you wash your hands, brush your teeth, so every day, 2 times a day. Yeah, actually, it's necessary for to prevent bacteria growth, and also to wash out glucose compounds, and also any carbohydrates from your oral cavity, because carbohydrates in oral cavity can be decomposed by bacteria which are present there, and they're decomposed in hypoxic condition, and due to this forms the lactic acid. Lactic acid and different other acids are produced in oral cavity, and maybe you mentioned, so someday you forgot to brush your teeth and eat something like bread or cake or something with a lot of carbohydrates, and at morning you feel that in your oral cavity you feel so very acidic taste, yeah, in oral cavity. So that's happened because of this bacteria. And this and the main composition of tooth is actually the same as in bones. Yeah, it's a calcium hydrophosphate or hydroxyapatite of calcium, and this it is very stable against mechanical lesion, but it's very unstable in acidic environment. And then when we have acidic environment, so very gradually both enamel and dentin can be dissolved by this acid. So, and that's why so, and you understand what's happening there. So lesion is it starts with a very small lesion, then it increases, and bacteria settling there, and when enamel is ruptured till the dentin, you feel pain when food taken there, or might be cold is coming to the place of caries, and you feel a very huge pain. But if caries perforates the dentin already, yeah, and reach to pulp, then we have a permanent inflammation in a pulp, and permanent inflammation in the pulp of course causes a very hard pain, and this bacteria can spread along these nerve fibers, and it causes neuritis, inflammation of out of oral cavity, and sometimes if it's lower teeth of mandibular teeth, and so they can spread even into connective tissue of neck, and from connective tissue of neck it can come into the mediastinum, and the most severe outcome of caries is of course mediastinitis, inflammation of mediastinum. So of course in 50% of cases it leads to death. So that's why caries is not just simple disease which dentists are handling, yes, but actually it's sometimes causing the irreversible changes like death. Okay, so that's general overview. So of course you'll have dentistry like a distinct subject, then you'll discuss it in much more details. Then let's talk about gingivitis. Gingivitis is inflammation of gingiva, so just might be usually happen due to injury to the gingiva and influx of bacteria there. So let's skip it. Periodontitis. So you know that tooth is settled in mandibula with the help of periodontus. So here it's covered by gingiva, so it's a dense connective tissue, like ligament. Actually, by density, it's like ligament, and it supports the tooth in mandibula or maxilla, and inflammation of this periodontitis causing the loss of. So it might be chronic, might be acute. It causes a loss of teeth. So that's because cementum is not properly attached to the lacuna of mandible and maxilla. So that's why periodontitis should be treated. So let's keep it. Oral inflammatory lesions. We have aphthous ulcer. It's a canker source. canker source. So it's here is this image of after ulcer. So maybe some of you had it. So it's unclear what's the cause of it. Might be some injury, might be some chemical lesion. Features unclear. So I mean, cause is unclear, but we have it, and we can clear it just by use of anti-inflammatory smears. Okay. Then we have herpes simplex virus infection. Herpes simplex virus infection, so it can cause, so here we don't have image of it. So it's a cold sore, it's a recurrent herpetic stomatitis causing. So it's okay. Of course, in dermatology, you'll discuss what is herpetic virus, and it might affect even oral cavity. Then oral candidiasis or thrush. You might be heard about it. Especially, it's more affected children, and every person can have this oral candidiasis. So due to Candida albicans dissemination in oral cavity. So sometimes, usually it happens due to some chronic influx of Candida albicans, might be lesion of microbial flora. So when after use of antibiotics, for example, and might be some special stem of Candida albicans which spreading in oral cavity faster. Okay. Predisposing and also another predisposing factor, of course, is immunosuppression. So that's why most of HIV positive patients in AIDS, when AIDS is evolved, they used to have this Candida albicans, and you might be you've seen these pictures of AIDS patients. They have always whitish smear around the mouth. Yeah, and this is actually Candida albicans, and some patients who are on immunosuppression, like after the surgeries or due to autoimmune diseases treatment, so they also might present with this candidosis. It's just usual inflammation by the same mechanisms of inflammations are evolved, but it is caused by Candida albicans. It's a fungal infection, Candida albicans, most common. Then proliferative and neoplastic lesions of the oral cavity. So here it's a fibrous proliferations like fibroma of tongue, yeah, and here, and also pyogenic granuloma. Pyogenic granuloma, so okay, fibroma understandable, yeah, so just some fibroblast is producing too much fibrous tissue in proper place. It's a typical definition of benign tumor, yeah, and it might happen everywhere, not only in tongue, so in the skin, in organs. So that's why it's not a point to discussion. So, but it bothers the normal life, normal mastication, normal tasting. So that's why usually they come to doctor to remove this fibroma. So, but here is a pyogenic granuloma. So, what is a pyogenic granuloma? It's a cause of chronic inflammation. Yeah. So, for example, here you see this caries. So, caries containing tooth. So, it causes gingivitis. And in case of chronic gingivitis, untreated chronic gingivitis, of course, it can cause the pyogenic granuloma. This granuloma should be treated with surgical methods. Of course, we should remove the cause of the granuloma. Caries containing tooth should be treated or removed, usually removed. And of course, granuloma also should be removed from the oral cavity. Leukoplakia, erythroplakia. So, cause is cannot be explained. So that's actually this is leukoplakia. Here you see this histological structure. This is a typical stratified squamous epithelia, but this epithelia is a little bit metaplaced. So this is so not metaplaced, it's displaced. Yeah, and that's you see different shape of nucleuses are there, and they produce too much. They follow connective tissue along with it. So that's why an epithelial lining became keratinized. So like on the skin. That's why we see this sore-like feature with a whitish appearance. Because of what it's whitish, it's because of multiple layer of keratin which is present, so it makes this area whitish. Then it might be erythroplakia when blood vessels are also following along the connective tissue. It leads to erythroplakia. So, but principle is the same. So some also just like might be due to lesion, might be due to genetical changes. So it leads to metaplasia or dysplasia of epithelia with the formation of stratified squamous epithelia in oral cavity. Then and it is predisposition for squamous cell carcinoma. So squamous cell carcinoma is a pretty rare condition nowadays because we don't use chewing tobacco in such amounts as we used it in 19th century and 18th century. But if you use, so you are in danger, yeah, because squamous cell carcinoma is the main commonly caused by chewing tobacco and cigarette smoking, especially without filter cigarette smoking. Much commonly it's due to chewing tobacco, like nasvai, in Kyrgyzstan it's very common. This squamous cell carcinoma, but in cigarette smoking right now, only few cases causing this squamous cell carcinoma of oral cavity. Usually it's due to tube smoking or might be cigar smoking, so this thick cigars here smoking, because very excessive noxious stimuli is present in oral cavity. So mechanism is similar as in lungs. So chronic inflammation, chronic irritation with chemicals and causing inflammations, and chronic inflammation causing the dysplasia, metaplasias and dysplasia causing the aplastic changes and finally lead to cancer. Okay, so here is the squamous cell carcinoma. You see this picture. Of course, normally epithelial lining is thinner. So here you see this keratinized bulges here in deepness of epithelial lining. So it's a typical presentation of squamous cell carcinoma. It doesn't matter, it might be in skin, might be present in oral cavity, or even same features you can find in trachea, bronchial, larynx, and so on. Okay, 1 minute. So here you see this, due to this lesion, epithelial lining, so producing keratinocytes. So this keratin is appeared in abnormal place. So normally keratinous layer is present on the superficial layer, but due to dysplasia, due to improper loss of polarity of cells here, they produce it inside. So this is squamous cell carcinoma, how it looks like here. So disease of salivary glands, you have to remember that there are three major salivary glands like parotid, submandibular and sublingual parotid glands. And we have a large amount of other salivary glands, so that's why we can treat them like one organ, yeah, but actually they are different organs. We claim them as one organ. So let's talk about xerostomia. Xerostomia, so it's a dry mouth result from decrease in production of saliva. So it happens due to autoimmune sea organ syndrome. So it might be sometime happens, and it affects not only salivary glands but also eyes. Yeah, so it is affecting the how it's called, lacrimal gland. Finally, I found it out. Lacrimal gland. So might be lack of cellular secretion is a common complication of radiation therapy. Sometimes it's a side effect of some drugs, especially anticholinergic drugs, so like atropine. Yeah, atropine causing it, and actually premedication before surgeries, before sometimes even before the dentistry. So it's atropine. You then when you take atropine, so this muscarinic receptors are blocked, and saliva is not produced in proper amount. It leads to dry mouth. It's just xerostomia. It's just symptom of some other disorder or complication of treatment. Sialadenitis, it's inflammation of salivary gland, might be caused by trauma, viral or bacterial infection, or autoimmune disease. So most common cause of sialadenitis is mumps. It's a viral sialadenitis. It's mumps disease. It affects different exocrine glands, and it's good if it affects only parotid glands. So that's why usually parotid glands are affected. But sometimes, along with the parotid gland affection, it affects testes in males, yeah, and causing the inflammation of testes. It's testes, and it is okay. So, inflammation of testes, and also can cause the infertility in future if it's sterility sometimes. But it's pretty rare. Don't worry that not every person who had mumps, so they are sterile. Not, of course, but they are very commonly. It's one of complications due to mumps. Mucocella is the most common inflammatory lesion of salivary glands. Mucocella is the inflammation of salivary gland duct. So its inflammation causes the obstruction of salivary gland, and it leads to dilation of ducts in the salivary gland, and all the mucus which is produced by all saliva which is produced by gland is remained in salivary gland, and leads to increasing of size. Same bacterial sialadenitis. Its most common infection is Staphylococcus aureus and Streptococcus viridans. So it is related to immunosuppression, of course, and usually it might be acquired by hospital-acquired infection. So we had some reports in the groups about hospital-acquired pneumonia. So along with them, so very commonly Staphylococcus aureus, main cause of pneumonia. So same Staphylococcus aureus is the main cause of bacterial sialadenitis. Is not very common, and but if you can't find the other reasons, so you have to remember the autoimmune sialadenitis, Sjögren syndrome. So keep it in mind in chapter number 5. It's when autoimmune disorders discussed. So Sjögren syndrome was explained. Okay, neoplasms of oral cavity. They are morphology is very simple. But it gives 30 physiologically distinct tumors. We don't have to discuss all of them. So it might be approximately 40% of submandibular gland, 50% of minor salivary glands, 70 to 90% sublingual tumors are cancerous. Parotid glands, 15% to 30% of tumors in parotid glands are malignant. Okay, different types of adenoma is okay, just let's keep it. Odontogenic cysts and tumors. So odontogenic cysts is derived from remnants of odontogenic epithelium, they're present in jaws, and the exoskeleton epithelium line cysts are quite common in jaws. These cysts are subclassified as either inflammatory or developmental. Only the most common lesions are considered here, starting with developmental cysts. Yes, it's explained here, but you don't have to learn it, so just skip it during your answer. Now let's talk about tubular digestive system. Actually, what we had lectures about in histology, esophagus. Finally, we discussed esophagus. Once again, as you said before, esophagus is the main function of esophagus. Of course, is a passage of food from oral cavity towards the stomach. That's only function. and other functions are just additional or supportive to this. Acquired disease of the first rank gamut, from little cancers to persistent heartburn, gastroesophageal reflux, and maybe chronic and incapacitating of merely and occasional annoyance. So, esophagus. So let's talk about obstructive and vascular diseases. So obstructive diseases of esophagus, they include atresia, fistulas, and duplications. They're congenital diseases. So atresia might be heard. It's when abrupt closing of esophagus. So it's developmental issue. So when you remember when formation of oropharyngeal membrane happens, when if oropharyngeal membrane is not rupturing, then ectoderm is not joined with endoderm within oral portion. So it might lead to atresia. Fistula, so what is a fistula? It's a joining of different organs like esophagus with trachea might be there, so it leads to fistula. It's when mucus of this and this is joined, so might be congenital, along with congenital, so sometimes might be due to inflammatory changes, due to, for example, you swallow some bone of fish and it stuck in the esophagus, it ruptures the esophagus, causing inflammatory changes there, and causes also inflammation in trachea, and after this we have fistula. Of course, this condition should be treated very rapidly with a surgical procedure. So both of them, atresia, fistulas, and duplications also should be there. So because it's outpoaching of esophagus, so causing some effects in childhood pathology. I think you will discuss it. So usually they are discovered shortly after birth because a child cannot cannot properly swallow it, and as much he swallowed, as more it's vomited. So that's why it requires very radical surgery. So directly after birth. Okay, functional obstruction. So this and functional obstruction should be discussed. Functional obstruction is also named as esophageal dysmotility. It's a process can take several forms, all of which are characterized by discoordinated contraction or spasms of the muscularis. Muscularis externa, of course, it meant. This muscularis externa, so normally esophagus should be contracted in the same way as digestive tract, entire rest of digestive tract by peristaltic movements. But if it's not happening, so due to stress or due to improper innervation, so it might lead to functional obstruction. And this term, let's talk about achalasia. So achalasia, so it's incomplete lower esophageal sphincter relaxation. So when it is a spasm of lower esophageal sphincter, so I remind you, lower esophageal sphincter is a portion which connects esophagus to stomach, and it causes the lower esophageal sphincter tone, esophageal peristalsis. So then no proper transmission of food happens. So it is happen to failure of distal esophageal inhibitor neurons. So cause is idiopathic. So we don't know the real cause of it, but we have to handle it. So, but we have secondary achalasia. So, for example, in Chagas disease, so which is caused by Trypanosoma cruzi, it leads to failure of lower esophageal sphincter relaxation. Okay, it's one of pathology which caused by Chagas disease. Ectopia. So ectopia of esophagus is very common due to neighboring with the stomach. Especially ectopia, so most dangerous for us is ectopia of stomach mucus membrane into the esophagus. So as I said a little bit before, maybe I said, I don't remember, but esophagus contains stratified squamous epithelia. Stratified squamous epithelia, which is necessary for protection against mechanical tearing, mechanical frictions in esophagus. But in case of ectopia, but stomach producing gastric juice, which contain a lot of acids and also contain proteolytic enzymes, and it leads to but if this portion of mucosa is present inside the esophagus, so it causes a lesion directly inside the esophagus, and stratified squamous epithelia can't stand in front of this acidic milieu, and it dies, and it leads to metaplaced or even sometimes displaced, and it might lead to Barrett esophagus, esophagitis, dysphagia, and sometimes even into adenocarcinoma. After Barrett's esophagus, typically appeared adenocarcinoma of the esophagus. So the ectopia is not so simple as it seems like. But this gastric heterotopia might present in not only in esophagus but also might present in small intestine, large intestine, and it also creates some troubles in treatment. So, and very important for us now is esophageal varices. Esophageal varices is a abnormal dilation of the esophageal veins. And we used to hear about varices in testes, varices in lower limbs, but esophageal varices, so what's the main cause of it? Esophageal varices mainly caused due to portal hypertension. In histology of the liver, we discussed a little bit that portal vein is collecting blood from all organs, of peritoneal cavity, and it collecting into the portal vein into the liver. It passes through the liver. But later we'll discuss. We have some pathology of liver which lead to portal vein hypertension. So when liver cannot afford to pass blood through its parenchyma, so we need to squeeze this blood somewhere else. And for these features we have shunts. So we have portacaval shunts or anastomosis, portacaval anastomosis, and we need to pass this blood from portal vein into the vena cava inferior or superior. And we have this anastomosis in esophageal region, especially in distal esophageal region. And but this anastomosis are very thin, very small veins, and they don't use to pass some blood from it, and they are arranged just to passing the blood from esophagus. So esophagus, for instance, is not collecting blood into the portal vein predominantly. All products which are absorbed in esophagus, they are directly going to vena cava superior. But if we have portal hypertension, we use these small veins for passing of portal venous blood, and of course it dilates these veins improperly. And the dilation of these veins causing varices, walls of these veins being very thin, and due to injury with some tearing food, when you swallow something which is tearing, so it might rupture this vein. It leads to profound bleeding, and this profound bleeding empties into the stomach. And that's why patient doesn't mention it in beginning, and he feels just a little bit fatigue, so all the symptoms of blood loss, but no specific symptoms of it. So just fatigue, face is a little pale, but he doesn't mention it, and stomach is fulfilling with the blood, and then some portion of this blood comes to the digestive tract, and it is referred as internal bleeding. Internal bleeding. And this internal bleeding, but if stomach is fulfilled with the blood, so just imagine stomach volume is 1 liter until 2 liters. Depends on personality. 1 to 2 liters, and when it's filled with the blood, so just imagine 1 liter or 2 liters of blood are already lost from the body. already lost from the body, and at this moment starts the first symptom of this. First obvious symptom of esophageal varices. It's vomiting with the blood. Vomiting with the blood. So, and when vomiting with the blood happens, so it might be too late to do something, and usually patients dying due to this, and that's a main cause of death in case of portal hypertension, this esophageal varices. And we can help them by hemotransfusion. We can help them with endoscopic surgery, by which we bind this esophageal veins. But still, if a patient already has this portal hypertension, so we can hardly help him without transplantation of new liver. So that's why usually these patients, if they are not in the best clinic with a lot of liver for transplantation, usually these patients dying. Dying not in the same day, but after some time. So according to blood loss, we can maintain them with the transplantation or transfusion of blood, but still it's not so much effective for a long time. Okay, esophagitis, inflammation of esophagus. You remember the histological structure of esophagus includes mucus, mucous membrane, and as well everywhere we have mucus, so we have potential inflammation there. Mainly it is happen due to laceration. Lacerations happen in syndrome which are named as Mallory-Weiss tears. Mallory-Weiss tears. Mallory-Weiss tears are very commonly happen in alcoholics due to chronic vomiting. So when persons are vomiting almost every day, so you know what happens during the vomiting. So opening of esophageal sphincter, yeah. So distal esophageal sphincter opens, and under the pressure, stomach juice enters into the esophagus. And when a person so one time vomiting, so that's okay, so it can be recovered. Second time vomiting, so also we can clear it. But if it happens every day for a long time, so epithelia became very thin, lamina propria became very thin, and small injuries are collected in one large injury, and it also may lead to lesion to blood vessels in esophagus. And usually it's present in alcoholics, as I said, and in alcoholics, liver is already damaged, and also very commonly we have already portal hypertension, which is cooperated with esophageal varices and vomiting, Mallory-Weiss disease, tears. It leads to profound bleeding. It is visible like hematomimesis. So hematomimesis, it's vomiting with the blood. So usually longitudinally oriented. Okay. Then chemical and infectious esophagitis. So chemical infectious esophagitis is inflammation caused by, as the name implies, chemical causes and infectious causes. So chemical causes. Which chemical causes you know? For example, some medical pills might cause it. For example, doxycycline, so which is tetracycline role of drugs. It's pretty dangerous for esophagus. It leads to this changes. You see, it's so in it's D, right. So this squamous epithelia became tears. So actually it's a viruses. So but it's still epithelia is very ruptured. So it's another diagram should be here. So here you see it's a lesion which is present here. It's inflammatory lesion. It might lead to epithelial changes, and as well it's inflammation, so epithelial supplement of blood is decreased, and it leads to desquamation of epithelia, and of course also might lead to occult bleeding. Bacterial inflammation so might be caused by herpes simplex, cytomegalovirus, fungal organisms, they're very commonly causing it. So might be also esophagus can be involved in desquamative skin diseases like bullous pemphigoid. In dermatology we discuss it. Then, so 1 minute. So infections might be caused by fungi, bacteria, might be viruses, yeah. And usually, if you talk about not viral causes like bacterial infection, so they are usually predisposed by lesion. As I said, so most common cause of this mucosal lesion is bone of fish bone, or maybe other bone. So when you swallow something which is tears the epithelial lining and the mucosa of esophagus, so of course it can cause the settling of bacteria to this area. Okay, that's of course it's necessary to differentiate this with neoplastic disorders of esophagus, because it might lead to and actually chronic inflammation in this area untreated, so it might lead to metaplasia, dysplasia, and cancer. Okay, then most common diseases of esophagus is reflux esophagitis. Reflux esophagitis is happen due to reflux of gastric juice. Gastric contents reflux back. So it has congenital reasons. So might be insufficiency of distal esophageal sphincter, might be cause of improper dietary changes. So especially now you will understand me. So during the iftar, so who doesn't hold the proper eating in iftar? So when I understand that you are hungry all the day, yeah, but in the iftar you just eat a lot of food, too much food, and you fulfill your stomach with a lot of food in one moment. So but it leads to stomach leads to overextension, and due to this overextension, reflux is so the sphincter is not properly closing, yeah, and of course it leads to regurgitation of this food into the esophagus. And then esophagus might lead to in this reflux of gastric content, it leads to inflammation of this. First of all, inflammation due to acidic milieu, which is affecting the esophagus. But secondary reflux esophagitis due to chronic reflux esophagitis, so might be sphincter doesn't work properly for a long time, not only in orozo, but it's present all the time. Yeah, so it leads to Barrett's esophagus. So what is a Barrett's esophagus? Is a classical form of metaplasia. It's when stratified squamous epithelia of esophagus converts into the simple columnar epithelia, stomach epithelia, which is protecting epithelia against acids, but not against physical mechanical lesions. So that in this case, and Barrett's esophagus is a symptom, is a sign that that here we have chronic lesion, chronic inflammation, and due to this, Barrett's esophagus is a typical pre-oncotic disease. So it's not a tumor yet, but it very soon can be converted into the into the esophageal cancer. And adenocarcinoma of esophagus is mainly caused by this reflux esophagitis, the main etiological cause of it. Then, okay, mucosal injury in GRD, so we discussed it. Clinical features, so it usually happens in over 40 years of age, but sometimes it might happen in infants and children. So it's sore contained, regurgitation of sore contained happened here. Yeah, we have hiatal hernia. Also, it's a very common cause of this regurgitation of gastric juice is a hiatal hernia. So when some portion of stomach, so you remember this anatomy, yeah? So esophagus passes through the diaphragm, and directly after diaphragm starts the stomach, yeah? But what is hiatal hernia? So when some portion of stomach enters into the chest cavity through the diaphragm, and actually diaphragm also works here like supportion for distal esophageal sphincter. But here, when a hiatal hernia happens, stomach juice can easily penetrate into the esophagus and leads to same as I said, gastroesophageal reflux disease and with formation of Barrett's esophagus. Okay, then eosinophilic esophagitis. So eosinophilic esophagitis causes same symptoms as gastroesophageal reflux disease. Same symptoms like heartburn, also heartburn which appeared after the eating, or sometimes also might happen in fasting time. So here we see this blood. So this eosinophilic incorporations in the epithelia. So might be caused by. So we don't fully understand the cause of it. So might be some it might be autoimmune reason. So due to autoimmune reason, esophagus is injured. So usually related to other disease, and also might be caused by how's called parasites. Yeah, parasites in infection here. Okay, but sometimes we have idiopathic causes, so that's why we can't claim what is it exactly without histological examination. And here Barrett's esophagus. So here we see stratified squamous epithelium is normal, but here instead of it forms the stomach epithelia. Stratified simple columnar epithelium is located here, and here we should differentiate it with ectopia of stomach epithelia, or it's Barrett's esophagus. And this is a gross view of this. It's visible, yeah, that epithelia of and mucosa of esophagus reminds the mucosa of stomach. So it happens due to chronic reflux of gastric juice. So tumors of esophagus. So tumors are might be most common is adenocarcinoma. So and here again you should have a question. Yeah. So why we have adenocarcinoma in patients in esophagus when esophagus is covered with stratified squamous epithelia, and it seems like that squamous cell carcinoma is more common in esophagus, but adenocarcinoma actually more common because of Barrett's esophagitis, Barrett's disease. Due to metaplasia of so this metaplasia of esophagus causes formation of mucosal epithelia, and then this same mucosal epithelia is continue being involved by noxious stimuli, and this noxious stimuli can cause the dysplasia and anaplasia of this, which causes the adenocarcinoma. Okay, 1 minute. So here we have image of endoscopy. So yeah, here okay, and this you see most commonly adenocarcinoma and in distal portion of esophagus. And when it grows, so which clinical issues are there? Of course, it is the same features as in Barrett's esophagus. We have heartburn after, and also here will be obstruction of esophagus, and it will be vomiting with not gastric juice, without gastric juice, without acid. So when you swallow something, yeah, it reaches the distal portion of esophagus, but it cannot pass through it, and then it leads to antiperistaltic movement, retroperistaltic movement, and then it returns back. So that's a very common clinical feature of esophageal tumor. Of course, treatment of this disease is only surgery, subtotal gastrectomia and esophagectomia, So when we remove this esophagus and stomach, and instead of this portion of esophagus, we make small intestine. We just bind here small intestine. So okay, in surgery they'll explain much better. So here we see this lesion cells. So this is adenocarcinoma. So with this mucus is collecting inside the parenchyma, inside the deepness of this, not parenchyma of course, inside the deepness of this epithelia growing, the mucus is collected. And here we see atypical cells. So you see nucleuses are different in size. So somewhere mitotic figures are present here. Yeah. So this all features we discussed in previous semester about cancer, hallmarks of cancer and morphology of cancer. Okay. Squamous cell carcinoma, so pretty uncommon. So mainly caused by consumption of alcohol and tobacco, same as in lungs, yeah. But tobacco use, so it's very hard to swallow the tobacco, yeah. So might be related to chewing tobacco. Here it's or swallowing saliva during the smoking. As I said before, that during the smoking, if you are a smoker, so my recommendation, please spit out saliva during the smoking. Yeah, it's unpleasant to say, it's not well thing to do to spit out on the street, but just for your health, if you smoke, spit it out outside. And that's why tobacco smoking is recommended in special places where it's not too bad to spit it out. Okay. And synergetically, alcohol consumption and tobacco use increase the risk of squamous cell carcinoma. Okay, so also risk factors is papillomavirus infection, human papillomavirus infection, which first of all causes polyposis of esophagus, and then after the polyposis, it can be metaplaced and then causes this epithelial and displaced, and then causes the squamous cell carcinoma. Okay, so what clinical features discussed? Okay, let's continue with the stomach, the most important part, and we have 20 minutes for it. Stomach, disorders of stomach. First of all, let's discuss acute gastritis or gastropathy. So gastritis, so might be heard about acute gastritis, so from a lot of persons, yeah, and most of students have gastritis, and acute gastritis or chronic gastritis. So which symptoms of acute gastritis you would have? Of course, it's heartburn, usually based on so due to injury of stomach. We have acute gastritis. I remind you, in a stomach we have very acidic milieu with proteolytic enzymes. Epithelial of stomach pretty well preserving it against these chemical lesions, but it is simple columnar epithelia. It's a one layer of cells which cannot protect against mechanical lesion. So that's why it was strongly recommended to you many times not to eat food without drinking of water, or try to eat more liquid food, so melted liquid food. So then you can during the swallowing of it, you won't lesion your stomach epithelia, because esophagus and oral cavity is pretty well preserved against this tearing, but esophagus is not, but stomach is not. And then what happens actually? So when you wash out, so when you rip out the epithelial lining, so under this epithelium we have absolutely non-protected layer of mucosa of the stomach, and all this acid with pepsinogen, which is activated pepsinogen pepsin, can cause a destroyment of all connective tissue in mucosa, and even cells which are not protected cells which are present there in the mucosa of stomach. And sometimes this lesion might reach even deeper. So, but it is in next portion of this discussion. It will lead to cancer. So ulcer. Sorry, ulcer, but later also can cause cancer. Okay. Mainly it's related to consumption of inflammatory drugs, alcohol, so maybe bile excretion, increased bile excretion into the duodenum, or stress-induced. Stress-induced gastritis is very common. Okay, inflammatory drugs, anti-inflammatory drugs. So they are like aspirin, yeah, steal salicylic acid, or any of painkillers, NSAIDs. Yeah, so you had the pharmacology, you know, what is non-steroid anti-inflammatory drugs. They work on the same principle. They suppress the activity of cyclooxygenase, but along with this suppression of cyclooxygenase, it leads this inhibitory function of this cyclooxygenase is there in the stomach, and it leads to increasing of acidic activity in the stomach. And okay, later it is shown. So normally, yeah, here it's shown. Defensive forces: surface mucus secretion, bicarbonate secretion. So that's and gastric acidity peptic enzymes cannot injure it. But if due to injury, so some portion of epithelia is destroyed, then mucus production is also decreased. So due to non-steroid anti-inflammatory drug, so mucus secretion is also dumped properly. So then and also here might present H. pylori infection. Yeah, you know that this bacteria, which is normally settled in the stomach, so due to this noxious stimuli like ischemia, shock, delayed gastric emptying, host factors, stress, or any just improper food intake, so it leads to dissemination of this Helicobacter pylori into this mucosa lining and cause inflammation, which later might lead to ulceration. So that's why actually gastritis is a prerequisite for ulcer. So that's why. So what happens here? Inflammation is happening here, but still a lot of epithelial cells still remaining here in the surface of stomach. It protects it. It tries to protect it, produce some mucus, or at least it decreases the acidity of products here. That's why it's not active process going on here. It leads to just gastritis. It's also bad. It's also annoying. Yeah, but still it is not. It not ruptures the lining. But in ulceration, when you see, we don't have stages, yeah, of this. So you see directly after epithelial lining atrophy, so it directly reaches the muscularis mucosa. Yeah, you see, we don't have injury just by stages here, here, and here. No, directly if it ruptures, so all of these portions below mucosa and muscularis mucosa, so they are destroyed by gastric mucus, by gastric juice, and it reaches directly, of course, submucosa with and here it's respond with the bacteria, because here cells which are present here, they died and they produce necrotic debris, and then our anti-inflammatory, so pro-inflammatory leukocytes, like polymorphonuclear leukocytes, they are coming to this place and try to decrease this, to remove this necrotic debris, digest it, and then cause the reparation. There's macrophages which are also very soon appear here. They form granulation tissue, and they just little bit try to prevent further ulcer progression. But usually it's not enough, so that sometimes we need surgical treatment of ulceration. Nowadays it's rare because we have very good medicamentous treatment of ulcer, but still sometimes when ulcer progresses even through the submucosa and to the muscularis externa. It leads to profound bleeding. So, and here we have to make surgery, and also might lead to perforation of ulcer. Okay, so here you can read about it. So another predisposition factors I want to mention is Zollinger-Ellison syndrome. Zollinger-Ellison syndrome, you remember in histology we discussed that we have endocrine cells in the stomach, but same endocrine cells in the stomach, same endocrine cells are present not only in stomach, but they are also present in duodenum, and also they are present in pancreas. And this gastrin secreting hormones, gastrin secreting cells, they are present everywhere, and as well as every other cells, they can be tumorous. I mean, they can form tumor, benign tumor, but hormone producing tumor. And excessive production of gastrin, I remind you, gastrin causes the active production of pepsinogen and hydrochloric acid in the stomach. And this benign tumor of neuroendocrine cells there, causing the increased acidity of the stomach, extremely increased acidity. And of course, epithelial lining cannot handle it, and it leads to chronic gastritis and chronic ulceration. Okay. So what's the role of non-steroidal anti-inflammatory drugs? So that's and you see, when you prescribe the non-steroidal anti-inflammatory drugs, the most common drugs which you prescribe, like ibuprofen or other things, so you have to pay attention to its pharmacodynamics. You see, cyclooxygenase is inhibited by NSAIDs. That's the main cause of it. And what is cyclooxygenase dependent synthesis? So it's E2, I2. So actually all prostaglandins are produced, but for us more important right now E2 and I2. It stimulates nearly all the above defense mechanisms, including mucus and bicarbonate secretion, mucosal blood flow, and epithelial restitution. Yeah, so you see, and if we use non-steroidal anti-inflammatory drugs, all these protective mechanisms are destroyed. So this what is COX-1, COX-2? So it doesn't matter right now. So you have to first of all keep it understanding of what is the role of non-steroidal anti-inflammatory drugs. Helicobacter pylori, which is urease secreting, especially in uremic patients. So Helicobacter pylori might cause the injury. So that's why patients with uremia in kidney pathology, so in chronic kidney disease, especially in kidney failure, so Helicobacter pylori evolved much better, because urea, which is present there, so it's a nutritional compound for Helicobacter pylori, and Helicobacter pylori can cause the ulceration. So that's why it's not obvious thing to remember, but please stock it in your mind that in patients with chronic kidney disease, they are in a risk. It's a risk factor for, first of all, stomach. Yeah, so it leads to stomach ulceration, and also can be present with occult bleeding. Occult bleeding in the stomach, so and might lead to internal bleeding. And actually, I had patients during my practice which they had kidney disorder. I mean, chronic kidney disorder, kidney insufficiency, and also along with it appeared the ulcer, and they died because of bleeding, internal bleeding. We could do nothing with it. So that's why kidney insufficiency, kidney failure, so also might lead to internal bleeding. So reduced mucin and bicarbonate secretion have been suggested as factors to explain the increased susceptibility of older adults to gastritis. Okay, that's understandable. Then we have remained chronic gastritis. It will be next lecture. We'll discuss it in next lecture, along with the small intestine and large intestine pathology. Okay, let's check your attendance now. Okay, in the chat too. Okay, thank you. If you have no more questions, do you have any questions? Guys, no more questions
No, sir.
about today's topic?
No, sir.
No questions. Okay.
No, sir.
Question, Hamza?
No, sir. No, sir.
No, sir. No, sir.
No question. Okay. Thank you. See you next time. You can go.